To the NDAC. Welcome to the NDAC weekly webinar. I'm Catherine Foley, a researcher at the National Drug and Alcohol Research Centre, and I will be chairing your webinar today. I'd like to pay my respects to the traditional custodians of the many lands on which we live and work, and which for the panellists and myself today is Gumbaynggirr country. We pay our respects to elders past, present and emerging, and extend that respect to any First Nations people here today. Well, I'm very much looking forward to today's presentation. We'll be hearing about a study that sought to determine optimal access to and engagement with service delivery for the provision of opiate substitution therapy and/or needle and syringe programs in the UK. Quite the mouthful, and by the sound of it, it's going to be a really interesting presentation. I'm delighted to introduce our speaker on this important topic, Associate Professor Steve McGillivray. Now, Steve is lead of the Substance Use Research Group in the School of Health Sciences at the University of Dundee. He has a background in psychology and a PhD in health services research, and Steve has worked in harm reduction services and as an academic in psychiatry, general practice, epidemiology and public health, and mother and child health. So a wide range of expertise there. I also have the pleasure of introducing Dr. Alison Seckel, who will be joining us a little later for the panel discussion. Dr. Seckel is a regional doctor who wears many hats. Her clinical work spans primary care as well as the hospital system, with roles in opioid substitution therapy and women's health. Alison's important clinical work is complemented by her work in the university sector, where she is a senior lecturer at the UNSW Rural Clinical School in Coffs Harbour and a senior research fellow at the National Drug and Alcohol Research Centre. We'll have time for questions at the end of Steve's presentation, so please do send them through. And a special reminder to send your questions through the Q&A function rather than the chat function. I will present these questions to the panel at the end and will endeavour to get through as many as I can. So please settle back and enjoy the presentation. And Steve, I would invite you to start, and a warm welcome.
Thank you very much, Catherine, and thank you to NDARC for facilitating this. And already I've enjoyed visiting NDARC. I've seen practice, and I've also seen lots of research. So I feel very welcomed in the country. Thank you. So I'm going to kind of try, and it'll be fairly high level because there is an awful lot of detail of the study that I just won't be able to cover in the time. But I want to try and give you a flavour of what we've done, why we've done it, and what we found. Of course, it was a collaboration. I've got lots of co-ops there, a fantastic team across the UK. But particularly, I'd like to mention Peter McCulloch and April Shaw. They were the ones really the heart and soul of this entire project. And indeed, they will be first authors on any publications and the final report, which is due out at the end of this year. They're just so fantastic. They know the service well. They accessed all the data. They collected most of the data, and we were involved in analysing that together. Okay, so I'm going to tell you about understanding the contextual factors about OST and NSP specifically as they relate to improving access and engagement with services. So in order to get the funding, of course, we this all worked. There we go. We of course sort of argue for the need, and essentially in the UK, it's the NIHR, National Institute for Health Research, that funded this. In the UK, we have one of the highest rates of drug-related deaths in Europe, indeed the world, and Scotland is indeed world leading in that regard. We've had recent major outbreaks of HIV, and we need to minimise HCV transmission. We know that OST and NSP services are effective for a whole range of outcomes. There's lots of good evidence for that. But lots of people aren't accessing them, or if they are, they're dropping out. So we need to understand how services can be more effective in promoting access and engagement and retention of people who use drugs, people who inject drugs, to prevent, reduce harms and deaths. So the overall study aim was to generate in-depth knowledge of the contextual factors and mechanisms that influence the use and non-use of OST and NSP. And as I say, it's optimal service delivery in this entire project is conceived around successes in access, engagement, retention, and successful exit from service. It was, and still is, a multi-method study. Throughout, we have patient and public involvement, as NHR like to call them. We like to call it lived and living experience. And it was a multi-phase with several objectives. So phase one involved a meta-synthesis, that objective one, and I'm going to focus on that today, and an online survey. I'm not going to mention that, but anything I don't mention will be available in a full report that I can certainly share with NDARC and anyone that wants it. Phase two was a realist evaluation, and that met objective 3, and I'm going to talk about that. And as part of a realist evaluation, what you have to do is develop an initial program theory, and then that informs a refined program theory through data collection. I'm going to describe this in a bit more detail. And that leads to phase two, the second part of phase two, which is the costing implications of the output from our refined program theory. And that is currently in the hands of our absolutely fantastic health economics team in Bristol. They're currently twizzling the numbers as we speak. So I won't be speaking to that either today. So the main data I'm going to mention today regards a meta-synthesis of 63 qualitative studies and a realist evaluation using a site case study approach, which involved 86 study participants from 3 UK sites. So I'll talk a little bit more about that. So meta-synthesis, why do that? Well, we know that there are previous reviews out there on this kind of issue about treatment uptake and so on. But they've tended to pretty much focus on barriers and facilitators and list or describe those factors with limited or conceptual theoretical transformation of the data. So what we thought we would do is, first of all, is to conduct a meta-synthesis to identify and create a better understanding of these contextual factors, whilst also focusing on the barriers and facilitators, the impact on use of services. And as a really important aspect of the meta-synthesis was to use those findings to inform the conduct of the subsequent realist evaluation. So to inform an initial program theory. And we'll come to that just a bit further down the line. So the meta-synthesis, I'm just going to give you this sort of high level. The detailed account of the methodology is available. We published a prior protocol with Prospero. We conducted a comprehensive search of multiple key sources of data. We conducted critical appraisal, and we followed broadly the methodology of Noblet and Hare in terms of analysis and synthesis. Our inclusion criteria for studies were that they ought to understand the optimal provision of any of these services, OST or NSP, from the perspectives of any key stakeholders whatsoever, whether that be staff, service users, anything, but that the study must have some relationship to understanding or the impact of access, engagement, retention, and successful exit. So here's the sort of newer Prisma flow diagram that shows the kind of flow of the finding of studies. I mean, overall, the short headline is that there were more than 2,000 possible records that were included and screened, and subsequently included in the review were 63 studies from 67 reports, 10 of which focused on NSP and 53 on OST. So 63 studies, 38 of these studies were published in the last 5 years. I should say one of the other exclusion criteria was anything published before the year 2000 as an arbitrary kind of cutoff of recency. So 38 published in the last 5 years, and 44 of the 63 were assessed as methodologically probably weak. We dichotomized in terms of possibly strong, probably weak, determined by how well they did in terms of triangulation of data, theoretical sampling, rigor, reflexivity, credibility, relevance, and so on. The studies, well, they were from around the world, but not surprisingly, like so many systematic reviews, the vast majority were from North America or Europe. Of course, UK isn't in Europe now, so we have our own little setting there. You'll see that 6 of the studies, 11%, hailed from Australia. And if you look at the study participants, you can pretty much see that the vast majority of these studies were people who were service users. That PWID should also have / people who use drugs as well as inject drugs. So the vast majority were service users themselves. So 20 of the included studies, 13 OST and 7 NSP, included nearly 500 staff participants, and 53 studies, 45 OST and 8 NSP, included about 2,500 service user participants. I just put this as an interesting note at the bottom that none of the studies, as far as we could tell, included any commissioners of services. And that's important when we come to our realist evaluation. So the analysis broadly follows quite a laborious trawl through all of the data that's presented in the individual papers, and a kind of extraction and analysis of first-order constructs that are found in those papers. And those are direct quotes of study participants, so primary data, if you like. And then second-order constructs are those author interpretations, which also include thematic analysis and so on. So we coded at those levels, and then we related and translated the concepts and the constructs. We clustered similar concepts, and we translated original concepts into reciprocating concepts from other studies. So just to give you an example of some of the first order and second order constructs. So first order, from the review by Bochco, 2016, a direct quote from a service user. For me, it is an important argument. Even if I want to be enrolled, I'm afraid that I will be very limited in my movements. I like to travel with my children to different places. I'm like everybody else. This is the reason, and also the fear that I have no job. I fear they will not employ me, God forbid. The very enrollment in the program limits and restricts me in many ways. So you can see that that relates to access and fear around sort of problems with accessing the service. The second order construct in this kind of similar area is where Damon et al., and this is an author interpretation of their analysis of the primary data, participant accounts illustrated how perceived coercion during OST initiation corresponded to lower levels of trust and negative views towards OST, which sometimes led to OST discontinuation. So you can see how that speaks to issues around discontinuation and thus, engagement and so on, and issues around coercion and so on. So you can see how we can actually start to triangulate some of the first order and second order constructs to try and explain and understand issues around access and engagement. So we've got lots and lots of that kind of data. And then we have this magical exercise, which I really enjoy. And we use the kind of whiteboarding exercise where we actually put all of these concepts, all of these constructs and so on, onto a whiteboard, and we start to map them and look at relationships and so on, and start to develop our analysis. And this is just like a zoom in of one part of that whiteboard. And you can see that one of the issues that kind of loomed was the concept of power and control. And it came from different areas to do with things to do with autonomy, feeling controlled by effects of medication, coercion, and that could be direct or indirect, and systems and services themselves, the rules and contracts, not knowing the game, change of rules, not being part of creating the rules, staff themselves, services being inflexible, judgmental, oppressive, and controlling. And don't forget, all of this evidence is entirely inductive. We're not mapping anything onto this. This is all rising up from the data in the studies themselves. And then, of course, we've kind of evidenced where lots of how rich or not this data is. So, for example, we have a table which shows for each study where it contributed. So, for example, we have this kind of third order construct that we've developed from those first and second order constructs around the issue of power and control, of which there are some sub-themes, one of them being restriction and inflexibility, for example. And you can see these are individual studies that contribute meaningful data to understand those specific things. So we have that throughout the data. All of this will be available in the report and the subsequent publications. And then you can have a general map of where the studies contribute to these higher order concepts or themes that we developed. And you'll see the labels there: power and control, stigma, knowledge and information, and goals, needs, and preferences. I'm going to say a bit more about those. But what you can notice, and this is just an abbreviation of a long table of all the 63 studies, you can see that actually there's quite a rich data set across all of these third order constructs. So I've mentioned power and control being kind of one of the high level concepts here. And across the evidence, findings indicate that service users feel powerlessness, over-regulated, and thus lack control in their dealings with OST and NSP. And also there's good evidence across a wide range of studies, settings, and countries that services can be inflexible, restrictive, with coercive practices, which lead to a lack of autonomy, dissatisfaction, engender various fears, and thus act as a barrier to service uptake and continued engagement. The second kind of high-level construct is that of stigma, not surprisingly. I mean, so many studies mention or focus stigma, have that as a main theme of their discussion. And the evidence, when you pool it, suggests that stigmatization within systems and services, as well as enacted stigma from service staff and from other service users, are further barriers to access, engagement, and so on, particularly access. And indeed, a high level of sort of monitoring and surveillance that needs to be that happens in services impacts directly on service user identity, trust, experiences of confidentiality, anonymity, and thus influence access, engagement, retention, and exit. If anyone's aware of any of this literature in any way, shape, or form, this will not be a surprise whatsoever. The other high third order construct that was important was knowledge and information, such that service user knowledge and beliefs and misbeliefs and so on of the potential impacts and consequences of treatment in relation to drug harms all influence their decisions around uptake and engagement. And knowledge and information highlights the importance of service users being made aware of services, so that knowledge about what services are available and when and how do you access them, so that they can make informed decisions. And it also underlines the importance of partnership working between services to ensure that they're working in a common way and that they disseminate and communicate and enhance awareness of services and routes of access and so on. So that was quite an important set of findings across all the studies. And then a really rich data set across many studies was the issue of what we've termed goals, needs, and preferences. And that's important to have that kind of multi-concept heading, because it's not just about goals of treatment. It's not just about, needs of treatment and immediate needs. There are wider life needs, and there are also preferences. People have different expectations, people have different needs and different preferences to meet those. And so the evidence suggests that person-centered services that are capable of meeting these different treatment goals, wider needs, and providing options and choice are more effective and better received. And the provision of a range of services offered at different thresholds for which service users have choice also appears to be important. And services that provide options and choice regarding wider supports, especially regarding on-site wraparound service models, may actually help to facilitate successful access, engagement, retention, and exit. So one thing I suppose promised early on is, the other reviews that have done this sort of barriers and facilitators haven't actually gone on to do any of this further on analysis and actually postulate an explanatory model which could account for the data, which would be interpretive, which would deepen the understanding of contextual dimensions and indicate interrelations, and allow people to actually look at it and map their experience and service to it. And so this is the model, the explanatory model that we've come up with. And essentially, service users are at the middle, the center of that, service user-centric. The actual outcomes of access, engagement, retention, and exit are just around that, around the service user. And outside of that, we've got those wider cultural, political, and organizational influences and issues. But all of the data that we've collected speaks to these interrelated groups of power and control, knowledge, goals, needs, and preferences, and stigma, which all interact and overlap to influence access, engagement, retention, experiences, and so on. So that's a whistle-stop tour, high level, of the meta-synthesis, and it answers its own questions too about, you know, what are the main drivers of these access and engagement issues and so on. But also it provides an output to inform the realist evaluation. So I'm just going to go on now and just start from the beginning of our realist evaluation proper and describe that. So the aim essentially was to undertake a qualitative, in-depth realist evaluation using a case study approach to establish the contexts and mechanisms that impact on the use and non-use of OST and NSP in the UK. And a realist evaluation has, well, three main steps. And actually, if you read around realist evaluation, and you read any outputs, any papers that describe them, they do vary quite a bit, but there's kind of a core approach. And this core approach is firstly to develop an initial program theory. It's where you describe context and related mechanisms that are theorized to result in optimal service provision for whatever your outcomes or outputs are deemed to be. Step two then, once you've got that initial program theory, is to go and test it. So you test that via in our case, via qualitative interviews with key stakeholders. You go and collect evidence, hold that up to scrutiny, test it, and that should lead towards the development of a refined program theory that is explanatory and can answer the question of, you know, what is an optimal service? What does an optimal service look like? How does it operate in order to improve access, engagement, retention, and exit? So the initial program theory is the first thing, and that's identified and developed by generating hypotheses about the potential interactions between contexts, mechanisms, and outcomes. And if you're not familiar with this, this might sound a bit abstract just now, but I am going to actually show you how we've done that. And so really these CMO configurations, as they're called, can help to show how and for whom and in what ways a particular program or service can operate optimally. So what you might note here is this is step one, the initial program theory, and this is how we went about developing that. And you'll see at the middle of that is the explanatory model that I showed you at the end of the meta-synthesis. So that actually formed quite a core to influence the description of initial program theory. So the meta-synthesis output, we also conducted a survey of all commissioners of services across the whole of the UK. So that's Ireland, England, Wales, and Scotland. We conducted a documentary policy analysis of all policies in the home nations in the UK. We've had various PPI groups, lived experience input, and other stakeholders, key stakeholders, staff members, and so on, and experts in the field, in order to actually put this kind of through the mill to describe what initial program theory might look like, what the context, mechanisms, and outcomes were, using the output of the meta-synthesis as a starting point. And this is what we came up with. I'm showing you high-level stuff, but there's lots of things underneath this, but these are the main context, mechanisms, and outcomes. So you can see context plus mechanism equals outcome. So in the context of power and control, which we've termed the context of controlling and restrictive services, if service users have the choice between different thresholds, low threshold, medium threshold services, and so on, that choice, they're more likely to access and continue engagement. If service users have a degree of power via person-centered approach to make decisions, improvement in outcomes. If service users are supported to develop strength-based competencies and self-esteem, leading to positive social networks, a sense of belonging and purpose in life, improvement. Service user groups encourage engagement and routes of advocacy to ensure that they have a voice in the services provided. And then the second context, the context of stigmatization and alienation, staff recognise the importance of confidentiality and non-stigmatizing approach, which leads to positive relationships with and increased confidence and trust of service users. And then service users are supported to develop strength-based competencies and self-esteem, leading to positive social networks, sense of belonging, and so on. And then service users are supported to increase their recovery capital through engagement with communities of interest to them, increasing social connectedness and support. And in the context of knowledge and information, the context of misunderstanding and uncertainty, then if partnership working is encouraged, if there's effective service dissemination and good informative peer network programs, if all staff are trained in drug use issues, harm reduction and safeguarding, then that leads to successful access engagement and so on. And then the fourth context is the context of goals, needs and preferences, which is the context of personalised services. And the mechanisms that broadly were generated from this context were that a single shared recording system, locally and nationally, was required to help manage care planning and so on, and movement of people through systems. A commitment to providing services that facilitate a shared ethos, understanding and responsibility between all key stakeholders. Services providing a range of options. Staff being supported and resourced to overcome the barriers that they have to deliver good treatment outcomes. Appointments taking account and being personalised and taking account of personal circumstances. And then meaning consultation with service users, such that their needs, goals and preferences can be identified and met. And one thing you should notice from this is that lots of this language is actually quite negative. The context of controlling and restrictive services, the context of stigmatization and alienation, this is all generated from the evidence, particularly that kind of qualitative in-depth evidence. And it's something that we, through subsequent realist evaluation, we come to challenge and turn around quite significantly. So step 2 then is to actually go and test this IPT, to go out and conduct semi-structured, in-depth interviews with a wide range of key stakeholders. And we did this in three sites across the UK, one in the west of Scotland, one in the southwest of England, and one in London, in a couple of boroughs in London. And we've maintained anonymity throughout, such that we did interview people in some small services, so we've not identified specific areas, so just more general sorts of areas. And the recruitment, we aimed for 72 overall, we achieved 86. And you can see that we interviewed service users in contact and using services now, service users who may have used in the past but were out of contact, non-core services staff, staff in core drug and alcohol services, managers of those core services, and then commissioners of services. And just to give you a quick flavour of the study site characteristics, essentially, if you look at the notes, all 4 sites were mainly urban, so they do have some potential to reach rural populations, and that's one limitation that we have. A range of drug-related death rates, sites varied regarding the richness of multicultural communities. They all have a degree of shared care with GPs. All sites have pathways that include specialist medical models. All sites have pathways that include specialist pharmacy models. All sites have examples of fixed and outreach models. And third sector organisations were only part of pathways in the 2 English sites, but not Scottish sites. And the NHS involved to some degree in pathways across all the sites. So the in-depth interviews generated a wide range of verbatim views. The data suggested that stakeholder views actually viewed services as effective and important, with many deficits. So there was really quite a positive spin on a lot of this. And across and between sites, there are examples of best practice, but also weaknesses and where service needs to be improved. So what we did then through this analytical process was we refined that IPT, those context, mechanisms, and outcomes that we had, and it indicated that power and control is actually better understood as agency and empowerment, stigma as self-esteem and respect, knowledge and information as knowledge and communication, and goals, needs, and preferences actually needed no reconceptualization, as that was already very person-centric and continued to be of particular importance. But a new context emerged, that of resources and demands. Actually, one thing I didn't mention is there was some things in the meta-synthesis that didn't really map to anything, but they kind of related to staff well-being and so on. They are actually now captured in this new context of resources and demands, which actually loomed quite important. So just to say something about resources and demands, it's about understanding service demands to inform service delivery and design so that resources can be allocated appropriately. That's one of the main issues here. But also that staff are supported and resourced to overcome the barriers and their ability to affect good treatment outcomes. Core services need adequate, reliable, and sustained resources to create the right circumstances for good recruitment and retention of staff, because that was a massive issue that was different across different sites and in different areas, but certainly recruitment and retention of well-trained staff was an issue. Funding of core drug services and wider drug service-related initiatives needs to be sufficient, reliable, and accessible. And a range of key performance indicators were required to be measured to direct effective service delivery, ensuring that it remains person-centered. And I'll say something a bit more about that. So what we have is this shift from a kind of explanatory model towards a more refined program theory. We've now plugged in resources and demands to that model. But our refinements also indicated that we needed to shift these mechanisms a little bit. So there's a reduction in the number of mechanisms for the first four, and then we've got new mechanisms coming in for the new context of resources and demands, and then further refinements to order to capture the person-centeredness. And a lot of this was determined by input from different key stakeholders, lived and live experience, and so on. And this is where we got to generate. Remember, this is top line, so we have a lot of sort of details underneath this. To generate these new context, mechanisms, and outcomes for our refined program theory. So now our agency and empowerment context is now the context of shared decision-making. Service users are empowered. Services should be low threshold with a range of tailored options. Service users have access to those involved in their care, direct access. Self-esteem and respect now no longer stigma, the context of identity and belonging. And it's about recognizing and actualizing the importance of confidentiality and a non-stigmatizing approach across the service, and that service users are supported to develop strength-based competencies. Knowledge and communication was about proactive partnership working, embedded peer network programs, staff having the knowledge and skills, and goals, needs, and preferences were about recording systems, those sort of care planning and so on systems being fit for purpose, commitment to providing facilities and services that had a shared ethos, a full range of services, a very wide range of services that are needed and that are not always provided. And appointments are personalised and take into account individual needs so that services can be flexible and shift to individual needs. And then I've sort of mentioned some of the resources and demands thing about understanding demands. We know that lots of people who are making decisions about how resources should be deployed and how services should be configured actually don't understand or know what's happening on the ground. Staff should be supported and resourced, core services, adequate, reliable resources, and funding is sufficient and reliable, and so on. So these are the mechanisms, these are the contexts and mechanisms. But our analysis suggests that the hypothesized identified mechanisms actually have specific mechanisms of action, and that these can be looked at in terms at two different levels: systems level, so high level strategic influences upon delivery of services, and service level, so that direct delivery. But our analysis also identified the importance of mediating mechanisms, so those things that can operate to increase the likelihood of those mechanisms reaching successful outcomes. And I'm just going to try and operationalize some of that by just selecting a few of the mechanisms for you. So here we have the context of agency and empowerment, shared decision-making, and a mechanism where we're suggesting that service users are empowered via a person-centered approach to make decisions regarding treatment. And the mechanisms of action to allow this to happen at systems level, well, funding of services and adequate staffing levels comes through quite a bit. Also, those safeguarding policies that are developed and enacted. At the service level, proactive case management care planning, consistency of key worker, negotiation of optimal dosing, staff confidence, knowledge, experience, purposeful listening, working at the pace of the service user, timely access to treatment, informed choice, a whole range of different mechanisms of action, which can then mediate through self-efficacy, motivation, and trust to lead to improvement in the outcomes. A few example quotes here: empowered via person-centered approach to make decisions regarding treatment. So in an optimal sense, so I did take-home medication. When I went on holiday, I went camping with some friends, and I did the take-home doses, and it was lovely. It just made me feel like a completely normal person, like it's not even a thing. I love it. I assumed it was because I had to prove myself. I had to prove that I was not going to abuse it. And I think now it's almost like having a reward taking home doses. So a service user from site B feeling empowered. And then we have a more suboptimal, which is the lack of flexibility within the system. And the site A manager reflects on that. If people are working, they can only be seen after working hours. Then we are flexible as much as we can around that. So we're kind of optimal, but suboptimal and maybe not as flexible as what we would be ideal. So moving on to an example from the second context, self-esteem and respect, identity and belonging, and specific mechanism where service users are supported to develop strength-based competencies, recovery capital, and self-esteem. Funding of services and staffing capacity and capability are important systems level mechanisms, but in terms of service level, peer workers are incredibly important and help navigate services and choice. Strength-based approach from the beginning of the treatment pathway is important. Focus on issues beyond prescribing. Time for wider and more supportive conversations. Consistent key worker signposting. Provision of additional activities, mobilizing recovery capital, and leading to mediated through positive social networks, belonging, confidence, self-esteem. Now, I've got example quotes here which really do bring it alive. And if I've got any time, I might go back to some of these, but I just want to cover each of an example from each of these mechanisms in case we run out of time. And I definitely want to leave a chance for questions. So the context of knowledge and communication informed decision-making, a peer network program is embedded into core drug services. Systems level, there should be adequate and sufficient funding of peer programs. Peer capacity and capability needs to be delivered, and dedicated space, the infrastructure from which to run peer involvement programs. These really came up as a really important part of service delivery that were often ancillary and not quite embedded. So peers embedded within each part of the pathway are the service level mechanisms. Informal and formal approaches to their involvement, formalized approaches to appointing and employing, core funded peer coordinators and peer team leaders, and so on. Training for peers. And mediating mechanisms where actually this was really important in engendering trust in service users, in confidence, in belonging and purpose, and also in reducing burden on core drug service staff themselves. And some excellent quotes. We really do have lots and lots of detailed quotations that support this. And in terms of the goals, needs and preferences, quite a rich data set around this. The mechanism of a commitment to provide services that facilitate a shared ethos was really quite important. And there are systems level policies. In Scotland, for example, we have the Scottish Government led medication assisted treatment standards about how services should be delivered, and everyone can aspire to those. But service design and delivery should be directed by service user goals, needs and preferences itself at that systems level. And then at a service level, shared understanding and responsibility, close formal working relationships between different services, negotiation and agreement of shared care planning, and opportunities for inter and cross-agency training and meetings was seen as absolutely crucial. And it's mediated through this shared ethos that improves access, engagement, and delivery of the service. And then just one example of resources and demands, and there are quite a few mechanisms in this one, but this one is about a range of key performance indicators, which relates to this idea that, you know, there are these hard and soft targets, but mostly it's the hard targets that services have to meet. And so the argument is that there should be this range of key performance indicators. And at a systems level, resources should be directed towards achieving results in strategic priority areas and taking account of not just hard targets, but soft. And at the service level, that there should be reliable capture of those different outcomes. There should be measurement of contextual information around different outcomes and awareness and measurement of hidden outcomes. And this is mediated through services remaining person-centered, such that services are improved. So it's kind of a really fast whistle-stop tour through some of the data. And I just wanted to, I've got a couple of minutes because I do want to kind of leave the voice of some of the participants of this on here. So I've just got a couple of quotes that I want to read to you. One is regarding short-term funding. So resources and demand, short-term funding. It's such a challenge within the third sector. This is a non-core staff member, so not part of the core drug service, but still delivering drug services. Because you're constantly on short-term funding contracts and the funding is never extended because it's good work. You're then having to find another funding pot and slightly shift your focus to fit into that funding pot. So it does mean, in my view, that you sometimes lose some of the efforts of what you're trying to do because there's not necessarily the scope to have this kind of natural learning and progression in any piece of work. I think our ambition as an organisation exceeds our ability financially to deliver. I would say that every single staff member goes way above and beyond. And I think that's a third sector trait. And perhaps it's a statutory trait as well. It is, because other people quote the same in statutory. I don't know, I can't speak to that experience. But you always go over and you work extra and you go well beyond, and your job description is because you're there and you're working directly with people. So of course you would. And that's one of the things that came through this realist synthesis that we did, speaking to these key stakeholders about what works and what doesn't work, is the examples of people going above and beyond in restrictions to deliver services. But that has implications for retention and recruitment of staff, burnout, and so on. There are many other quotes and so on that I could mention, but I'll stop there and leave some time for questions. Thanks for listening.
Thank you, Steve. Terrific presentation and really interesting work. So many questions. One thing that struck me is that word powerlessness and the voice of people. So really important work bringing together the evidence that we have with the perspectives and views of the people that are most affected by service delivery. So congratulations, a really important and big piece of work. Alison, I would like to invite you to now just give a couple of minutes reflection, turn your camera on, you're on. Let us know what you're thinking about this presentation. And Steve, if you would like to stop sharing your screen, we'll be able to see Alison.
Okay, that's the back of my office at the University of Dundee.
Thank you.
Thank you.
Thanks, Steve, for stepping us through a very, very complicated review so clearly and logically. It was very easy to follow, and I really like that realist review. with the use of mechanism to really get to the nitty-gritty of why things succeed or don't. It seems like a really fantastic model to get to where we need to. Really resonated as a opioid agonist therapy prescriber. We really need to have that patient-centered, client-centered, consumer-centered, service user-centered approach. And sort of, thinking about the way we think of services, that really strong therapeutic alliance really came through what you were talking about. And that when you were talking about those 5 areas around agency, empowerment, self-esteem and respect, that, that reshaping of an opioid dependence use problem as a chronic disease model rather than, a societal issue or a stigma was really, really important. So I really enjoyed that.
Thank you.
Thank you, Alison. Thanks for joining us. So Steve, we've got a couple of questions on the panel. Firstly, Grace, and I apologise if I get your name wrong, Grace Prayel has said really great and empathetic approach. Appreciate that comment. James McGregor has asked, Steve, you mentioned commissioners. Would you mind just explaining who you mean by that?
Yeah, well, yeah, actually, I did think about that because I know that that's one of probably the differences in terms of, the Australian context and so on. But I mean, broadly speaking, commissioners, and the commissioners are usually kind of senior individuals within, well, we have healthcare trusts and so on, we have health boards and what have you, who actually, look to what service needs are and then make the case to Treasury and so on for, the health budget to say what's the budget envelope that we've got to deliver services over this particular time. So an awful lot of data collection goes in around, how are we working, what's working, what isn't, what do we need to do. There's lots of consultation and, managers and meet and so on. And budgets are then accordingly deployed. Now, so those commissioners are senior managers who manage services. So they sit above the direct service provision and actually look to oversee management of the service. And they're not all the same, it would seem, because some actually do have more of a background or a bit more of a knowledge of actual service delivery, while others don't. Others have come in from a management perspective and not from the coalface. But the commissioner voice has been completely missing from any of the literature we've seen before. And it's why with some of the rich data that we only had 6 commissioners, but the rich data that we have that bears on thinking about KPIs, thinking about, the cycle of funding. So, for example, some areas have managed, and this is by dint of the commissioner themselves, they've managed to negotiate lengthy budgetary periods, such that, often it's usually about a 3-year funding cycle, and then you've got to go through it all again. So what some people were talking about is like, oh, we have these great initiatives, everything's going well, and then suddenly everything's changed. We've no longer got the funding support, that we're into our next funding cycle, and we've got different priorities and so on. But some have managed to negotiate a kind of a 3+7, a 10-year funding cycle, such that initiatives really can continue on. So I don't know if that answers your question fully enough. I could go into the job description of a commissioner perhaps, but
yeah,
I'm not
that's
sure.
great. Thank you, Steve. James said that makes sense. Slightly different context in Australia, which is really important to note, but great inclusion. Thank you. We've got a question here from Jennifer Holmes. Welcome, Jennifer. Thanks, Steve. Excellent model. Please, could you provide a little more detail on the strategic indicators?
Oh, okay. Strategic indicators in terms of, well, which ones particularly?
KPIs.
So the KPIs. Yeah. Oh, can I quickly share again? Well, can I read a
Sure.
quote for you? This is a quote from Commissioner in Site B. And who is it that you need to convince that key performance indicators have to be more indicative of these softer targets as well? It starts with the national level, because if I can talk to elected members, I can talk to the chief exec and I can talk to the directors in the building, but they will always take you back to, well, these are what the indicators are and these are what we are measured by. So if there isn't a national strategy and there isn't a national framework around these qualitative elements, then the powers that be locally will always say, this is what it is, what we get measured by, and it doesn't look good. And I'm in the know to agree to a degree. I'm in that box as well because like I like to see greens across the board. I mean, don't we? We don't like to see reds on there because it's just that visceral element to it, isn't it? When you see a red, it's like God, So that quote speaks to those kind of hard, important targets. I mean, how many people are being seen? So that's just a number. It's not about the quality of the nature of that service. How many adverse outcomes, how many people are receiving, how many people are reducing dose or on a maintenance dose, or, these kind of harder, important facts. So I don't know if that partly speaks to the query.
Thanks, Steve. Thanks, Jennifer. Any further questions there, please feel free to pop in and we'll come back to those. I'm really curious. This kind of work is quite complex and challenging, particularly working across so many different, servers and stakeholder groups. I wonder what the key challenges were for the research team and how they overcame those, the million-dollar question, in engaging with people to actually have that conversation about what's needed.
Well, challenges. There are always challenges. I mean, I was brought up in research to believe that there are 10 changes at the beginning of any project, 20 in the middle, and another 10 at the end. The challenges were legion in this, not least the fact that we pretty much kicked off at the time of COVID. So imagine trying to do a national survey of all of the commissioners in the UK at a time of COVID when everyone's head is elsewhere. And so that was kind of, we generated some interesting data from that survey, but the response rate, if I remember, was about 18%. So, and that was despite many kind of iterations and rounds and so on. We had problems because of COVID in terms of accessing the sites, of getting the rights to be able to go in, of getting ethics approval. Teams were off. People were down with COVID. There were little kind of narrowings of pipelines of getting things done that were, down to one or two people who were suddenly not available. Whole systems and services didn't happen. So it's no surprise that the 2-year study has now become a 3-year study, and we've had no cost extensions. We've lost staff as well. But one thing, and how we really overcame all of these challenges, was tenacity, was having 2 of the finest researchers I've ever worked with, in Peter and April, who just really know services, know how to access key stakeholders. They've been at the coalface, they speak the language, they walk the walk. They were fantastic, and without them, the project would absolutely be nothing. And even when it came to analysis, it's getting our heads together and drawing in the expertise from the team. But challenges are plenty. If I touch on only a few.
Terrific, thanks, Steve. I think everyone can probably relate to that idea, particularly through COVID, of how challenging it can be, and service delivery in particular for people was really difficult. And I think what's really nice about that is engaging with the right people and the people that actually know what is happening at the coalface, to ensure that you're sort of doing something that is feasible, which is a challenge in itself. But fantastic work. I guess a final question would be, hold on a minute, we have another question here, so I'll go to that first. I would like to know if you have witnessed changes across your time in this area when it comes to treatment availability and outcomes in Scotland. Being new to the area and had recently looked at Scottish data, Grace was surprised about the scale of some of these problems and the lack of historical context for contextualising all this.
Yeah, no, I mean, that's a fair point. I mean, look, you go anywhere in the world and patterns change, behaviours change, drugs of choice change. But one thing that remains is there is a problem with substances affecting people's lives, and services need to be delivered. So in Scotland is no. I mean, I first worked in the drug problem service in Dundee 30 years ago, and of course the big issue then from the 80s was HIV and the shift to harm reduction, and that's kind of still where we're at, which is good. But changing patterns. I mean, Dundee, Scotland, are world leading in drug deaths. Partly that's driven by kind of street benzodiazepines and so on, polydrug use and what have you. So, and do services change? Well, do they change quickly enough to? Probably not, and hence why we need to be doing this research. Hence why we've got the MAT standards in Scotland to try and drive that change, but it's a slow process. But nevertheless, across the board, whether Scotland, whether England, what we find is that there are areas, not every area is delivering services in exactly the same way, and they all have slightly different challenges, and some are doing some things better than others. So this talk of optimal service delivery is actually a theoretical position that we have in the middle, such that anyone that's delivering services, whether in Scotland or wherever, can look at this and think, how do we measure up to these mechanisms? How are we delivering on these mechanisms? Do we want to? Is that how our service is configured and so on? So I think that's one of the implications from this research, is that we could potentially provide this framework that you can map your service to. But I think anyone looking at this, I mean, sometimes you do this kind of work and people, it's kind of, you're stating the bleeding obvious. We already knew that. And well, in some ways, yes, but this is entirely inductive, and it does actually, I think, lay out in a fairly mechanistic and easy to follow way, a way that you can map your service to. I think, well, where are we falling down and where are we doing well? Let's focus on those areas where we're going amber now.
Yeah.
I've rambled a bit around that question. I do apologize.
Thank you, Steve. Really, really interesting to hear. And I was going to ask for one very quick recommendation. What would be your very quick recommendation in this last minute or so that we have from your work?
I think a really quick recommendation is to, whilst we recognize, and I really made a point of at the end of talking about this, whilst we recognize the fantastic, amazing job that individuals do, and they're going above and beyond, it is not sustainable as an approach. And that whatever we do, we celebrate that, absolutely, but we need to support that. We need to resource that. We need to fund that. We need to harness that. And we need to allow people to be able to do a job that is incredibly challenging and that they absolutely love, so that they can continue to do that and be the best kind of, agent of change. So it would be that, I think.
Thank you, Steve. Thank you so much. Just like to take this minute to say thank you for coming to Australia and sharing your insights with us. Alison, thank you for coming along as well. We've come to the end of our time, so we'll just share our upcoming webinars and just let you know to please make contact with us if you'd like to hear from Steve or Alison in relation to what's happening in Australia and the work that she's doing. And we thank you all for coming along. And you can see we've got Dr. Sam College-Frisbee next week, a really exciting presentation. Please come along and join us. Thank you.
Thanks for having me.